Are we live?
Yes, sir. We have live now.
Okay, hello. Good evening, everyone, and good evening, madam. We welcome you to the monthly webinar of Indian Cartilage Society and all the viewers. Dr. Sasi sir and Dr. Karthik is here with us. And Dr. Elizabeth Vinod, madam, she is associate professor in Department of Physiology, and she's an adjunct scientist in Center for Stem Cell Research in CMC Vellore. So I welcome you, ma'am. And so today's topic is on her talk is on cartilage repair in osteoarthritis lessons from animal models and orthobiologics. So over to you, ma'am. Please share your talk, and you can
Okay.
share your talk on the screen, ma'am.
Yeah, I've already started sharing. I just want to know if it's visible.
Yes, yes, it is visible.
All right. Okay. Thank you, sir. At the outset, I would sincerely like to thank the ICS platform for this opportunity. Thank you, Dr. Karthik. Thank you, Sasi, sir. And so I will start with my talk, which is basically on cartilage repair and osteoarthritis. Being a basic scientist, I'll just give a perspective of how the different OA animal models have actually helped us come to where we are now, the differences in the various models, as well as just the recent advances in the context of OA, the orthobiologics, on how much we've progressed in the field of treatment of osteoarthritis, as in the cell-based as well as the cell-free therapeutics. So the main target is our articular cartilage, which is specialized tissue, hyaline in nature, and plays a pivotal role because of its articulation and weight-bearing properties. But however, being relatively avascular and aneural in structure, has limited self-repair capabilities, thereby requiring adjuvant therapies for treatment. So if you look at the ultrastructure of the articular cartilage, it is zonal in nature. And even among these different zones, there are various principal components. And if you were to appreciate the cellular as well as the orientation of the collagen fibrils, they vary among these zones. They have a different spatial arrangement, a dense network of these insoluble collagen fibrils, which therefore makes a repair of this tissue also a great challenge, especially for doctors as well as us who are trying to replicate the same in vitro as well as in vivo. So osteoarthritis, it was earlier just considered to be a wear and tear disease, but we know it's a painful chronic disease and is the most common form of arthritis, not just involving the cartilage, but rather the structures in and around the cartilage. It is the imbalance between the repair and the destruction that in fact leads to the changes that we see. If you look at age-related joint changes, you do have decrease in the proteoglycan, which is the extracellular matrix, as well as the collagen, which is type 2 primarily in the hyaline cartilage. And if you consider the osteoarthritis, how it differs is, in addition to that, it has a pro-inflammatory environment where you have a lot of pro-inflammatory factors that go up, and that inhibits the anabolism, boosts the catabolism, leading to the suppression of the ECM synthesis and therefore osteophyte formation, a narrowing of the cartilage. And there is a lot of these matrix degradation products that get upregulated, that in fact cause the various changes that you see with the different grades of osteoarthritis. Now, if you look at most of the human cartilage, we study comes from the joint replacement surgery. I'm talking at the perspective of a sample that we use to study. And at that stage, in fact, the osteoarthritis is already in an end stage and the tissue has shown damage, and we don't get an idea of how it has started. So essentially, we're in fact studying with the aftermath and not the disease process. So human OA, in fact, also another problem is it takes decades also in a few people to develop. So early tissue sampling, you could say, is in fact impossible with a human tissue, and that's where these animal models in fact help us come to understand this disease better. So these models allow us to define the time of onset, manipulate a single variable such as a load or an inflammation, and help us to also follow the progression over time. So most importantly, it will help us not only to test causation, but also association. And however, OA, as we know, it is not a single disease, it is heterogeneous in its nature, and no single animal model can in fact even recapitulate what happens in the humans. So that's in fact the real challenge in fact even choosing a best model. And however, choosing the right model is also dependent on the biological question at hand. Here is a histological picture, or just comparing, just to give a context of this is how a human cartilage looks. Those are the different zones that I've said. And this is a mouse cartilage. If you look at the thickness, it's around 2.5 mm as opposed to 30 micrometer in a mouse. So that's like 100-fold change. And you do not see the beautiful zonal that we see in a human cartilage. So one needs to keep this in mind even when we try and interpret the results from the animal models. But this is the best model that we have and which is more accessible for us to use and learn. Now, coming to the animal models of OA, they vary from small animals such as mice all the way up to equine and even non-human primates like monkeys. And I will come to that shortly. But nowadays, advances have gone on to use 3D cultures, organoid cultures, using organ-on-chip models where you can induce osteoarthritis, take cells, put probably interleukin beta, and cause an pro-inflammatory environment, and then study the disease model. Moving on to the models available in the animal category, rodents are what are most commonly used. One being they're cost effective, they're easy to breed, and it's ideal for any mechanistic study as well as for drug screening. And going on to larger animals, we have rabbits, sheep, goat, even canine, where they provide a closer anatomical and biomechanical similarity. However, these are expensive. They have a low throughput and involve greater ethical complexity. Coming to non-human primates, those are in fact the closest to humans, but they use nowadays are quite limited again because of cost as well as ethical consideration. So again, as I'm reiterating, the species choice is in fact a balance between what is the mechanistic clarity as well as the translational relevance on your question at hand. So animal models of OA, you can in fact classify them into primary OA models, spontaneous models, as well as secondary models. I'll quickly go through each of these models, the pros and cons of these, and then come on to the recent advances in the field. So coming to spontaneous models of the disease, primary OA aging, the common animal models used are the Hartley guinea pig models. This is what is commonly used even in PGI Chandigarh. Dr. Sandeep Patel has talked about this model quite often. The SRT as well as the ORT mouse as well as the rhesus monkey. So the advantages is it can cause cellular, it is prone to develop aging. So you can get a picture similar to that of what happens in a human. There is a whole joint involvement. It can also involve the bone where you know that the following pathways are triggered and it eventually there is matrix failure. But the problem with these models are it is slow, it's expensive, and it has limited control because it is what happens spontaneously and it is not under your control. You presume that at a particular age of this animal, the OA has developed, and then you put your intervention at hand. Moving on to genetic induction models, where we know there are various factors that get upregulated in osteoarthritis, few that get downregulated. So you can replicate that. You can increase the matrix catabolism, for example, metalloprotease 13 catabolism overexpression, and that causes collagen 2 degradation, inflammatory pathway activation, and therefore a picture of OA. So you know the precise mechanism that you're testing. There is no surgical trauma involved here. There is a very clean cut pathway dissection, but however, again, it's artificial, and there are often severe phenotypes and low translational predictability with these models. Moving on to chemical induction models, this is something that we hear also in CMC use. The most commonly used chemicals are monosodium iodoacetate, papain, and collagenase, where MIAs, they inhibit glycolysis, they cause chondrocyte death, and eventually, therefore, osteoarthritis develops. Papain, it's an enzyme, so therefore it will just digest the proteoglycans. Matrix will collapse. It will slowly cause an inflammatory kind of a cascadic picture. Collagenase is a little more aggravated form of creating a chemical model of OA, where it just not just degrades the ligaments, all the stability also gets affected. So it is a rapid, reproducible, low-cost model, and is in fact used better to study pain. But the disadvantages is you have direct chondrocyte destruction reconstruction, still it is not the replica of that what you would see in humans, and probably poor for studying different stages of osteoarthritis. Moving on to the instability models, which are most commonly used, where you can have the ACL ligament tear or the meniscectomy or a destabilization model. So joint instability will cause activation, that mechanical shear will cause activation of various factors that will finally lead to an inflosome activation and also affect the bone based on the grade or how long you would leave these models. So they are a mimic of post-traumatic OA. They reproduce mechanotransduction, do show cartilage loss, and there is a predictable progression with these models. However, it sometimes just the surgery per se is a comorbidity. It can induce inflammation. You can have an accelerated form also in a few, and there can be technical variability based on the veterinarian or the doctor who's conducting the disease. And still, this is not an aging or does not mimic the metabolic OA models. Just to complete this, what are the other models available? We have a non-invasive tibial compression cyclic model where you can actually apply a load, and we know that will cause activation of the primary NF-kappa B signaling, increasing these degrading enzymes, and therefore causing a bone remodeling and therefore affecting the cartilage. It does mimic post-traumatic, but it is purely mechanobiologically driven. You also have high-fat model where you take mice or rat and you feed them with a very high-fat diet, and that causes activation of adipokines that will cause polarization to a pro-inflammatory phenotype from an anti-inflammatory, insulin resistance, bone remodeling, and therefore cartilage being affected. The OVX model, where in fact the ovaries are removed, and therefore you have an estrogen depleted picture, and that will in fact cause most of an osteoporosis, which is now you have an unstable base, so therefore your cartilage get affected, is also a model that is being used to induce OA. So you have your osteoarthritic models where it's divided into primary and secondary. Any type of model will need an evaluation, and the most standard that is used is histology. Still continues to be histology. You do have imaging, scoring system, gait analysis, which are rather an additive to what histology can help us come to. So histology, you have various scorings. One of the most accepted scoring in case of an animal model is the OA RSI scoring. I'll come to it shortly. And you also have different scores based on what species, if it's human or if it is animals, and what are you looking for. In case of chondral defect, you have different scoring. Now coming to the OA RSI scoring, it's a beautiful score, I must say, because we scan these slides, we send this with the score to our pathologist who just scores them blindly and gives us a grade. It's a beautiful scoring system which considers, so here is just the cartilage, just sorry to explain the picture before I go into the details. So that's your different zones of the cartilage, that's your tide marks, that's your bone. You can see with increasing grade, so that's normal, grade 1, grade 2, grade 3, going on to grade 6. You see that your surface is from intact is being denuded, being discontinued with fissuring, going all the way down, being eroded, and finally a deformation of the bone. And this is a staining called safrano staining, which is a staining particular for sulfated proteoglycans present in your matrix. So that is also a factor that is considered, and it is used to help you decipher what grade of OA was achievable. But remember, generally to be able to do this, you will have to sacrifice or euthanize the animal to get your joint. So generally at the end point, confirmation of OA cannot be done for the same animal that you are intervening in. So just coming to the term orthobiologics, it's a wide and complex category. I'm not going to go into the details. It's a very familiar term for all of us, where you can have products, any substance that treats injury can be blood-derived. We know that PRP is one that's commonly used, and you have cell-based products. Those that treatments rely entirely on the presence or the administration of cells. So you can use tissue-specific cells. MSCs are used. There are also mononuclear cells are being used. And how these cell-based products are used are characterized into whether it's taken out from where its harvest site, it is expanded and given back, and that is referred to as the advanced therapy medicinal products, the ATMs. It has more complex regulatory pathways. And you have point of care products, where inside the surgery, you take an aspirate, say, for example, centrifuge, and give it back to the patients. So those are more of a heterogeneous population, but it's more affordable in terms of cost. Coming to pharmacological treatments, we know millions affected by OA, and generally before arthroplasty is offered, and if it's in an early grade, there are are treatments that target the subchondral bone, targeting inflammatory mechanisms, increasing cartilage metabolism, inhibiting pathways that would lead to further inflammation and relief of pain. But we know that most of these patients do end up needing an arthroplasty because of the progression of the disease. So looking at the current clinical trial status using biologics for osteoarthritis, so this is up to 2025, there is an increasing trend. But most of the clinical trials, they are in their phase 1 and phase 2, with a few progressing in the pipeline to reach phase 4. And this is basically the same graph taken from this paper. It was a nice paper which showed what were the advances and challenges of clinical trials considering stem cells for osteoarthritis. This is where India stands in the number of trials. And if you're going to look at the types of cells that were used for treating osteoarthritis, adipose-derived MSCs stood first, followed by umbilical cord MSCs and beam MSC. Mostly should be probably because of the easy availability and source. And the most common joint that was targeted was the knee joint. And so coming to what are the therapies that are available worldwide, and I'll come to the focus of what's in India. So we have the joint stem, the marketed authorized MSC cell-based products for OA. What stands out is joint stem. So what is joint stem? It's basically autologous adipose-derived MSCs. They are primarily in their phase 2 and 3 trials, and however, it's not a globally approved or standardized drug product. And then you have cart stem. Cart stem is allogenic umbilical cord MSCs for cartilage defects. It has completed phase 4 trials. Then you have the Rengenix. I'm sure we're familiar with this, which is autologous same-day bone marrow concentrate procedure. It is offered as a clinical procedure, but it's not an FDA-approved drug. It is supported mainly by registry as well as observational data. And then I just want to bring your attention to Stempucil, which is an allogenic bone marrow MSC product from India, has been approved for use for chronic limb ischemia as well as knee OA, and has been supported by phase 3 randomized control trial. In fact, 2 months back, they have put forth their results. I will try and present that too. So why MSCs? Because MSCs per se, they're known to be immunomodulatory, and considering the OA to be a disease that is in a pro-inflammatory as well as degenerative environment, the MSCs stand superior to that. And also they are known to be chondroprotective, being cartilage anabolic, as well as has anti-apoptic effects, lowering their effects in a pro-inflammatory environment. Now, coming to this trial, as I said, the Stempucil trial, it was a trial. In fact, it's completed its phase 3. It's been now marketed also, targeted for grade 2 as well as grade 3 knee OA. It was conducted over several multi-centers in India, major orthopedic research hospitals such as PGI, Chandigarh, St. John's Hospital, Bangalore, Kasturba Manipal College at Manipal, and currently it's been marketed under the brand STEM1 and Ciplostem through a tie-up between Stemputics as well as Cipla. It's been approved by the DCGI as well as the CEDESCO for use for indication of knee OA and also for chronic limb ischemia. So this study, what it does is, it basically has taken three donors, bone marrow MSCs. They have cultured them, they have pooled these donors, and at passage 3, passage means you take the cells, you put them on a flask. Once they reach confluence, that is when they start occupying around 80 to 90% space of the flask, you take them off and then you further split them. So say, for example, passage 3 would mean probably splitting them around 4 times. That would take actually some time to get that, because they needed a number of 25 million per vial to administer. So then they went ahead, did a characterization in process quality control across all these product was at passage 5, and they cryopreserved these cells and sold these vials. And why 25 million? They did do a dose study earlier, and they've come to the targeted population. So this was their study design, where they took 146 patients, randomized them into a group that did receive BMMC and to a group that received only the biovehicle, which was used to deliver BMMC, which had a component of HA. They analyzed these patients. So they had a huge inclusion criteria. criteria, just putting forth a few primary things. They did focus on early grade OA, grade 2 as well as grade 3, which patients who did show functional limitations, and even after using analgesics for 6 weeks. So that was the grade that they focused on, grade 2 and grade 3. They did have a huge list of exclusion criteria, and those should not have received stem cell therapy or should not have a malalignment and other indications. So these patients were in fact followed up for up to 2 years. And what do they show in their results? So just to give you context of the figures that's going to come up. So red being the arm that did receive Stempucil, that is basically the test, that is the pooled BMMSE of 25 million, one shot in the knee, as opposed to the placebo. Those placebos were just basically the biovehicles, which had a component of HA. They did see that the WOMAC pain score, there was significant reduction in the pain score at 12 months by 45% compared to the placebo arm, and also 71% by 24 months. Responder analysis also was good, with the VAS pain score even showing again a significant drop in the pain scores. However, between grade 2 and grade 3, they did not see any stark differences. They did MRI T2 mapping, which is basically an indicator of the water content. And so if it is bad, there is an increase in the relaxation time. So they so low T2 values means healthy, and high T2 means cartilage degeneration. And they did show in the red that there was a decrease in the T2 values, which showed that there was some kind of an improvement seen. But they said, finally did disclose that there is a need for long-term follow-up to confirm whether these were disease modifying or just elevating in terms of the grade of osteoarthritis. Now, coming to another form of orthobiologic, a lot of it has been coming up. So I thought I would also cover this. One being the paracrine factors that are secreted by these cells. They are also now being considered, considering the issues of immunogenicity. So MSCs were previously known. You can take them, you inject them, they go, they home, and they are responsible for the repair. But however, a lot of that ideology and school of thought has changed, and now we know that it is not the MSCs per se, rather the paracrine factors that majorly contribute, and a lot of attention to the use of extracellular vesicles. So these are basically the cargoes that are produced by the cells. Nothing, you grow the cells, you take the cells, you grow them in a medium. Rather than throwing the medium off, you collect that medium and then you harvest these cargoes. So anything that is secreted by the cell in toto is referred to as an MSC secretome. You can further use procedures to take out a particular component, and one of those components that are most talked about are the EVs, that is the extracellular vesicles, which includes exosomes, microvesicles, anti-apoptotic bodies, and the exosomes are what are being focused on. So it is the cargo from within the cell, which contains lipids, proteins, nucleic acids, DNAs, RNAs, and even mRNAs. So there are studies, there's very less data when you come to exosomes. It's a booming field. So secretomes from MSCs has shown to inhibit inflammation in an in vitro model of OA. When the ADMSCs, namely the adipose-derived stem cell secretome, was taken, and they did it on an inflammatory model of chondrocyte in vitro, they did see there was anti-hypertrophic as well as anti-catabolic effects. Equine, in fact, showed that there was an anti-inflammatory effect, evident rise of GAG with the exosomes or taken from MSCs. And also it did elevate pain in rat models, and there was a long-lasting pain relief seen with the animals that did receive it as opposed to those which didn't receive it. So with exosomes, or rather EVs, they have used BMMSC-derived, adipose tissue-derived, embryonic stem cell-derived, MSC-derived, and they do show a decrease in inflammatory mediators and some amount of augmentation of collagen 2 with the animal models. They've even gone on to further use miRNAs. These are basically non-coding RNAs that are not responsible for the protein coding, but has a significant role and in gene expression. So they have viewed, there is a list that they're now working on and seeing if they can target cartilage degeneration. A quick look into the registry. There are very few studies that have been registered to the use, and a lot of them are in the recruiting phase. So therefore, there is no studies, completed studies using exosomes in human OA. So is there a consensus with using cell-free orthobiologics as opposed to MSCs? MSCs more because it did have a head start. It is more cost effective as compared to the secretome. There are a lot of regulatory gray areas when it comes to EVs that are still being clarified. But if they can come into market, it will be a good off-shelf product where you don't have to worry about immunogenicities. So what do we do here in CMC? I just thought I'll give you a context. So we know that in clinical trials, the two most commonly used cells are MSCs as well as chondrocytes. So if you look at the sequence of chondrogenesis, we have MSCs in and around the joint. They, under transcription factors, undergo condensation and aggregation to give rise to a progenitor. This progenitor will eventually become a chondrocyte. Now, these chondrocytes in the resting state, they help contribute to the ECM and therefore the hyaline cartilage. But eventually, its life is, it undergoes hypertrophy, acquires a hypertrophic state, and therefore leads to contribution of bone. Bone has its own mechanism for formation of its cells, but the hypertrophic chondrocyte eventually become bone-like. So use of clinical, these two cells, namely MSCs and chondrocytes, one limitation that has been reported, there are a lot of improvements now in terms of bioscaffolds being chondroinducive to these cells and improving the outcomes. But one limitation that has always come out is the admixture of the repair tissue, which contains a little of fibrocartilage along with the hyaline cartilage. So therefore, search for an alternative cell source led to the discovery of chondroprogenitors, which are by nature inclined to become chondrocytes. So these are only, what are they? They're just a cell a step ahead of chondrocytes. And we see one important thing is they show a lower hypertrophic potential. So that indispensable combination. So we work with these cells and we are working these cells looking at how they are superior or can be superior to MSCs as well as chondrocytes considering their in vitro behavior. And in fact, the first clinical trial to use these cells is set to run hopefully this year. It's by the University of Birmingham as well as the Swansea University, where Dr. Elias is one of the senior consultants. The indication is in an allogenic manner for chondral defects. And we hope this study will give us some insight on its potential. So here in CMC, we do work with animal models, osteoarthritis, generally the MIA model, chondral defects, critical defects, put our cells of interest, compare it with others. We also harvest osteochondral units, work with chondral defect platforms. These are patients following RTA who require a bony amputation as a part of the treatment. So discarded joints are taken, we harvest these units, we place them under immunodeficient mice, we harvest them. So this is just one of our results where we see a comparatively better repair with our progenitors as opposed to MSCs as well as chondrocytes. We even work with extracellular vesicles derived from these cells in an OA model in rats, and we also see our cartilage resident cells to outperform beam MSCs in terms of repair. So thank you, and I can take any questions that are required. And if it's all right, if I have just a minute more, I just want to also mention before I close that I'm sure we're all aware of the recent Supreme Court order on stem cell therapies, and it reiterates basically that stem cell therapy is a standard of care, and it's currently approved mainly for, if you look at the list, it was more of these hematological stem cell transplantations for specific indications. There were about 18 adult as well as 14 pediatric conditions. And for other diseases such as OA, stem cell interventions is allowed to be carried only with proper regulated clinical trial control. And products such as Stempucil that have already undergone an evaluation through CEDESCO pathway falls under the regulatory biological framework, and the order mainly addresses the issue of unregulated stem cell therapies being offered outside the approved research or regulatory oversight. So going forward, I guess any new stem cell based therapy will need appropriate regulatory pathways that will include your institutional ethics committee clearance, followed by the National Stem Cell Research Regulatory Committee clearance. Then that's DHR, then CEDESCO. This is based on what kind of cell is it going to be less manipulated or more manipulated. And then you will need a CTRI before the first patient recruitment. Thank you.
Thank you so much, madam. It was a wonderful lecture, and we really had an interesting talk. And one question I want to ask, ma'am, almost we see that while using animal models, what we get are very good results. So, aren't we overpromised that while using animal models, we get a good result, and when we use these orthobiologics in human population, then we don't get those results. So, are
Yes.
the indications wrong, or are we lacking somewhere?
No, so Dr. Swami, the thing is, what would actually help you come to a conclusion is the controls that you use. So, for example, say I am using PRP and I'm using cells with PRP. So, ideally, I should give one arm which will have PRP blood my cells, and I should also include an arm that is plain PRP. But what is generally reported is PBS. You know, they use a control, and if it's PBS is nothing but in fact a physiological saline solution. PRP per se may also be as good as the test. So those are some things that a person who reads the paper should be critical about. So which is why I also feel there are a lot of promises over promising because of not proper controls being used, and I agree. And those who do use controls, the progress is slow for them. So it is yeah. I, it's true. There is a lot of over promising there, but I think it is at the discretion of the person who's going to decide. Should look into the details a bit more.
Why can't we form more of the hyaline cartilage? Because as you have shown that normally we get fibrocartilage more, but can't we get hyaline cartilage
It's a very
for?
difficult tissue to reproduce, sir. So that's what, as I said, what is used is MSCs and chondrocytes. Now, both of them love becoming bone. If you put them in bone, they will easily become bone. But hyaline tissue, it's very difficult because you don't want bone and you want this, and you want the zonal, three zonal integration. It is very difficult. So nowadays they're trying 3D printing them such that the orientation of the collagen fiber. So say if you want also bone and cartilage, 3D print a material that is good for bone, put BMMSCs because you know BMMSCs are good for bone. Then put in your 3D material which is good for cartilage, and then put chondrocytes. You know, so it's a lot more effort, a lot more cost involved. The tissue per se is a very difficult tissue to replicate.
Yes, right, ma'am. Sasi sir, any questions?
Thank you, Dr. Elizabeth. I think that was a wonderful explanation of all the scientific activities that are going on in cartilage reconstruction. And I totally agree that cartilage is not a homogeneous structure, unlike bone, which is more homogeneous than cartilage. And it is a very, very difficult tissue to reproduce. And also, when cartilage is very much superimposed on the subchondral bone and actual bone, I think all the mesenchymal cells, progenitor cells have the tendency and also the stimulating factors to get converted to bone as well. And that is also the reason clinically we a lot of times see intralesional osteophytes when we don't follow the surgical principles accurately or even otherwise. So I think the lot of important points were discussed. There was one question I wanted to ask. We were talking about secretomes, extra cellular vesicles. So when it comes to practical application, what is the formulation it comes in? When these particles, what is the formulation they come in? How are they stabilized when it comes to clinical application?
So currently, when you get these extracellular vesicles, they are stored in -80 or in a temperature that is lower than that. People are trying to create lyophilized, freeze-dried these extracellular vesicles so that it can serve as an off-shell product. But they are still in study. What is its stability and how long it's stable is still not known. Even now, all the administration in animal models is done directly from -80 or a temperature lower than that. As a room temperature product, I don't think so. It has reached that stage as yet, sir. And the idea, but the long-term goal is to get an off-shell product, create a formulation so that it can be stable at room temperature, can be just shipped in a vial that can be reconstituted and administered. that is the goal, and people are working towards increasing its stability.
Wonderful. That is clear. I think that was a wonderful presentation. Dr. Soumya, do we have any questions from YouTube?
No, sir. No questions.
So I think that was a very interesting talk.
Yes, sir.
If we don't have any further questions, we can conclude.
Thank
the
you,
session.
sir. Thank
Ma'am,
you.
I
Thank
have
you.
Yes,
one
sir.
question.
Yes, Dr. Karthik.
Recently, there was a news that some Stanford scientists have discovered a drug which is reversing the cartilage aging and is growing the cartilage again, the original cartilage, and which
Yeah.
doesn't require the total knee replacement at all. So, do you have any information regarding that?
Yeah, I think it's more of an interleukin antagonist, if I'm not wrong.
It's some
Yes,
linked to protein
linked to
15
protein.
GH.
Yeah. I think we'll wait for the long-term results. It seems promising. I mean, theoretically, it seems promising, but I guess the joint is an environment that is multifactorially dependent on a lot of things. So you end up targeting one thing, but you're not sure. But however, something is always better than nothing. So the patient, even if they have fibrocartilage in an empty space, they do feel better, but eventually they will require a replacement. So I think it's a bit too early to tell. That's what I would say at this point. Probably we could wait up for the follow-up results, and then let's see if it's promising, that would be really good.
Okay, thank you.
And ma'am, are you using this one papain for inducing osteoarthritis?
So yeah, so we've tried with as in papain is something that digests everything. So it becomes a very
Yes.
unstable joint. Collagenase is even worse. With MIA, monosodium iodoacid, we've been able to achieve different grades of osteoarthritis. Like if I want early grade, I can give a lower dose. If I want a later grade, I can give. But however, the MIA is tricky in the sense you will have to know how much of volume and how long you wait for OA to develop. So you'll have to dose standardize that against your animal model. We've been able to do it with rat. There was nothing, no data on rabbit, so we had to go ahead and standardize that for rabbit. We've come up with rabbit too. But doing so, I guess we would say even one of our animal studies, we didn't want a late OA, but we did get late OA. So it is tricky. It is dose controllable, but you should be quite careful. So we use MIA. It causes glycolysis inhibitor, chondrocyte death, and therefore it causes osteoarthritis. But again, it's not the typical spontaneous OA or the aging that one would see.
Okay. Thank you so much, ma'am, for a wonderful talk.
Thank you, sir.
And
Thank you.
thank you, Dr. Sasi sir, for joining. And thank you, Dr. Karthik. It was a wonderful webinar. So, and I thank all the viewers.
Thank you very much, Dr. Elizabeth.
Thank you,
Soumya,
sir. Thank
and
you for the
Vivek.
opportunity. Thank you, sir.